let us begin the wrap up, I think, with what Bill Bergen said, is that I-STEP, which was an Attorney General's proposal, would be, in his view, from his vantage point, a good start as well. And we have two people from the Attorney General's office who are going to be our next to last speakers. Gregory Krakauer is the Senior Advisor and Counselor to Attorney General Eric Schneiderman, and Gary Baldoff is a longtime career prosecutor. He actually looks like he's been a prosecutor longer than me. If he started in '86, I've been in the industry since '87. So he is also one who has a tremendous amount of experience and wisdom. So with that, let's bring up Gregory and Gary for the concluding remarks.
Well, thank you. It's been a long and interesting and very important day. The problem of prescription drug abuse and drug diversion has been analyzed here from a variety, an amazing variety of angles and perspectives. And on behalf of the Attorney General's office, it is just really appreciative. We really appreciate that members of community from throughout this state, from Buffalo to Brooklyn, have identified this problem, not as a growing problem or not as an exploding problem, but a problem that has exploded, a problem that is here. In the closing remarks, as part of our call to action, and some of in the last panel referred to the Attorney General's, what he spoke today about the I-STOP database. I think our slides are off, so I'm going to talk without the slides. The Attorney General this morning mentioned that we have the Attorney General, at the end of the last legislative session, introduced his really only program bill. Sometimes Attorney Generals in the past have lots of legislative agendas that they advocate for. Attorney General Schneiderman introduced one main bill, the I-STOP database, which has been talked about today, the internet system for tracking overprescription. And, you know, it's been said a lot today, so I don't want to repeat a lot what's been said, but our current database currently has a 45-day lag time, and it only involves data that pharmacists enter for dispensed medication. Very few doctors have very limited access to this system. The Attorney General's bill would create an entirely new system. It would be comprehensive, and in fact, he has proposed the most comprehensive system in the nation, with a four-step process that really would address a lot of what we've heard of today. Prior to, the state would create a database run by the Department of Health, which runs its current database, prior to issuing a script, because a prescription is a gateway to a drug in our society. A pharmacist, a provider, a doctor, would have to look at the I-STOP database to see a patient's prescription drug history. Upon issuing a script, that provider would have to enter in real time that the script has been entered. And to let you know what a change this is, right now, there is no tracking of prescriptions. Right? We could have 10 prescriptions issued to a single patient in a 2-hour period, and neither the government nor anyone nor the pharmacists know those scripts are out there. And you've heard today, but I'll say again, a script is a gateway to a prescription drug in our society. You don't need to sell the drugs on the street. If an addict or an addict gang or a criminal gang or a crooked doctor, they can sell the actual scripts. Hence, we have the problem of stolen prescription pads and forged prescription pads. So the I-STOP database will have a record of the script at the time it is issued, which is incredibly important because the system then says to the pharmacist, when the script is handed in, check. You must check. Is this a real script? Has it been issued by a real doctor? Is it been altered? The Attorney General this morning mentioned that, and many have altered scripts. There are gangs that sometimes target doctors. They become known on the street where the 3s can become 8s and the 2s can become 3s. But with a computer, if your script says 80 pills and the computer says, no, the script was for 30 pills, that's not only a yellow flag, but that script won't be issued. Or the pharmacist will call to make sure that it's not an error. And an addict will say, don't call, I made it up. And then there can be other aspects. So the pharmacist will have the ability to check the script, and then the pharmacist, oh, great, I have to do it entirely from memory. And then the pharmacist will have to record dispensation of the drugs in relative real time, which, by the way, is not a particular radical jump from where states are going today. As of January, Oklahoma is narrowing their window of when pharmacists have to report drugs dispensed to every 5 minutes. So this is the trend, and the Attorney General has taken the trend and gone beyond to create a model for the nation. And New York has in the past been a model for the nation in problems involving our medical system. New York created the very first, in the 1970s, Medicaid Fraud Control Unit. People in the 70s thought that was sort of odd that government would have a unit dedicated solely to Medicaid fraud back in the early 70s. It was actually a special prosecutor initially defined. It became so successful that within a few short years, every 50 states, Puerto Rico and Guam, created a Medicaid fraud control unit, and the federal government mandated it. So New York has taken the leadership in the past, and the Attorney General thinks it's time on this problem to take the leadership today. What are some of the benefits of this system, which has been discussed today, but I'm going to go through them quickly, because I want to end with a real call for your help. Doctor shopping. You know, you go to the second doctor. If an addict goes to a second doctor, or a drug gang goes to a, and I say drug gang, I'm thinking prescription drug gang, goes to a second doctor with a script, that doctor might issue a script if they knew the other one existed. You might say, I lost the first one. But the third doctor and the fourth will know, because they're required to look at the database, wait a minute, this is third, this is fourth, there's no way I'm going to issue this. No one would issue a third or fourth script. We think very few. And if you issue a fourth script, you found what on the street is known as compassionate doctors, which is the street slang for that's a doctor who in essence is a drug dealer in a lab coat, which of course is a very, very, very small percentage of doctors in this state, but a small percentage that can do an immense amount of harm. We call them doc-in-a-boxes. You might have heard that phrase, but sometimes when law enforcement uses it, we're talking about, in essence, a drug dealer in a lab coat with a prescription pad. But it is very, very hard. And I compliment the amazing work the U.S. Attorney's Office has done in the Western District, and that our office does with the Medicaid Fraud Control Unit, and that Special Narcotics in New York City, and the immense law enforcement that I've spoken to today have done. Because it is really, really hard and expensive to prosecute what we'll call a drug dealing doctor, a doctor who is deliberately selling scripts or selling Medicaid, or selling a prescription drug to patients and addicts knowingly. And that's very simple. In a heroin case, a cocaine case, if we see anyone distribute heroin or cocaine, you're guilty. And there's great deterrence value. But a deliberate distribution of a prescription drug, the doctor can say, well, my patients lied to me. We've heard that. Doctors have been victimized. My patients lied to me. Some doctors aren't victimized. Their patients aren't lying to them. But they'll say that in front of a jury, and if the witnesses are drug addicts or professionals, the jurors are likely going to believe the drug addicts. It is very hard to say, since we want practitioners to have the free choice to issue these wonderful tools of modern medicine to people who need them, it is very hard. We prosecuted, our Medicaid fraud prosecuted a doctor in Long Island, over $1 million, basically selling drugs. And we had to send in undercover agents to say things to a doctor that no jury would believe actually indicated that the guy was actually hurt. Wiretaps, undercovers, very difficult prosecutions. With iStop, though, that changes. It changes because the law says, and I think most providers would want to, you have to look at the screen. You have to look at the screen. You can't say you were lied to because a statewide database isn't lying to you. And if your patient said, well, I've never gotten this drug before and you see it on computer, and we know you've given the drug, we've got you. So it facilitates prosecution, which means it deters, Currently, and B&E does a wonderful job with the tools that it has been given, B&E, the State's Bureau of Narcotic Enforcement. But currently, there really is no way to check for stolen or forged pads, right? You have to actually have a record in a computer so that the pharmacist can check to see if it's a real doctor, real prescription. So even if you're relying solely on pharmacists, which, Oklahoma and California has some really good, upgrades to their pharmacist system, you'll never get forged or stolen or upticked scripts unless the pharmacist can say, this is really what a doctor gave you. And that's part of iStop's benefit. And finally, and I think this is critical, we view this database as not only a law enforcement tool, it might be what we lead in just because that's what we do at the Attorney General's office, it's also a diagnostic tool. The doctors will have a record of at least the New York prescriptions that someone gets and have errors, and we think that's a very useful and societal benefit. So we view this as a diagnostic tool and, of course, a law enforcement tool to deal with the prescription drug issues. I have a quick chart of how the iStop database would compare to the current prescription monitoring program. Again, I was able to go over that for memory. And I also want to point out to you that what our office does, and we're going to hear from our regional director, Gary Beldoff in Buffalo, but the Attorney General's office does not have jurisdiction in general over drug crimes. We have an organized crime task force that investigates drug crimes and that gets prosecutions in some major cases, but as a general rule, drug dealing and illegal narcotics are prosecuted by DAs and the federal government and not OAG. The main exception to that is Medicaid fraud. And you wouldn't think necessarily of Medicaid fraud as a part of the prescription drug issue, but it is. I mean, Medicaid fraud is a double disaster, right? The taxpayers are paying when the fraud is about diverted or addicted drugs. We're actually paying to increase the prescription drug problem. Medicaid spends $1 billion, $1.1 billion every 4 years on controlled substances, the vast majority of them properly given to needy New Yorkers. But if we increase, people have asked, if we increase a very small percentage, not that it's of fraud caught through drug diversions, you end up with great savings to taxpayers. In addition, and we've been working with the health insurance industry, you end up with savings to private health insurers who pay for this, because addicts, to the extent they can, will bill private insurers to get their drugs, and so will criminal drug rings. Then they'll get a bunch of others with cash, because the health insurers have, of course, databases that knows who pays for it, as well as does Medicaid. So great added benefit for that of prosecutions, because as the examples show, and what Gary will talk about is a single doctor can do a lot of, not only obviously immense harm to patients, but a lot of fiscal damage too. We've had cases with $1 million easily billed to insurers and taxpayers. And those are drugs given again to addicts that are really part of the problem today. So the Attorney General has made this his #1 legislative priority. And and speakers, I know we sometimes say, here's what we're doing for you. But for those who have sat through and have heard some of the tragic stories today, stories both presented in individual ways and through statistics and charts, help us. Contact, as the legislature will next meet in January, contact your state legislators. Tell them that this is the kind of database that we need. Contact your professional organizations. We have gone on a summer listening tour because we are working with, and we want to work with, pharmacists and providers and doctors and dentists and technologists and the federal government and local agencies. That's how you would build support for a legislative program. But there are reasonable concerns and questions when anything's new is done. Legislation is tough. I used to work at the state senate before going to the Attorney General's office. And citizen involvement, citizen encouragement is not just helpful. It's critically helpful. It can't get done without people saying, this is an important issue. This is worth it. This is important. And for folks who this would affect in terms of their practice areas, practitioners and pharmacists, you know, if you call your societies, the local medical societies, the local, you know, pharmacist reps, even teachers, you know, in colleges, tell them that this is something that you should call, you should know. We support this. This is a minimal burden. If Oklahoma pharmacists can do it, so can we. And by the way, I don't mean to say that pharmacists have not been cooperative. We have written support from all sectors as we've gone through the state. But we need your help. It is a call to action. And I think together, I think, you know, we can address this with new ways that addresses the real problem, the real truth, that the prescription drug problem and the law enforcement solutions and the regulatory solutions are different for this problem than it was with heroin and cocaine, because the problems are different, the prosecutions are different when you're dealing with substances that we all want legal. And with the vast majority of patients and doctors who just want to prescribe these wonderful products that let people not live in chronic pain, and some live at all, not be abused. And we thank you for sitting today, because education is part of that process. So I do want to lead to Gary Beldoff, who's our regional director of our Medicaid Fraud Control Unit, talk about what we do regionally. But on behalf of our office, you know, if I had 2 words to say, I'd say thank you.
Thank you, Greg. Good afternoon, everyone, and thank you for your attendance here today. I really appreciate this opportunity to speak to you and tell you about the role of the New York State Attorney General's Medicaid Fraud Control Unit in addressing the problem of prescription drug abuse. Now, as many of you are probably even unaware of our unit or what it does, I thought I'd just take a few minutes at the start of my remarks to kind of fill you in on what it is that we do in general before delving into a couple of war stories about some of the big cases that we've prosecuted in the area of prescription drugs. As Greg mentioned, the Medicaid Fraud Control Unit, or MFCU, in New York was the first of its kind. It became a model for the nation after the federal government took notice of the great success we were having here in the early days, decided it would be a good idea for every state in the nation that had a Medicaid program to have a Medicaid Fraud Control Unit, and now that is the case, and they're all modeled after the one here in New York. We received 75% of our funding from the federal government, and in 2008, we're very proud of the fact that the New York State Attorney General's office was named the #1 Medicaid Fraud Control Unit in the country by the National Association of Medicaid Fraud Control Units. Statewide, we have about 282 employees currently, but that number is going up as we speak. This is how they break down. The investigators are all police officers. They can do everything that ordinary police officers can do. Our 91 auditors tend to be the most tenured people in our office. They're very knowledgeable and have a lot of experience in the Medicaid program, and they're a great resource to anyone who needs to get information about how the program's working and what particular providers are doing by looking at their billings and so forth. They're great assistance to me because, you know, I'm a lawyer, not an accountant. I don't need to go through all that stuff. They present me with a nice little report, and it really kind of hits the mark. The staff in our office is located in 7 different regions across the state, and as has been indicated, I'm the regional director of the one here in Buffalo. And in Buffalo, we have 3 attorneys, including myself, and as of next Thursday, we'll have 5 investigators, 5 auditors, and a support staff. And we have basically on every fraud case that we work, 1 attorney assigned, 1 investigator, and 1 auditor at least. Geographically, we cover the 8 counties of Western New York. That's the territory of our region. Our legal jurisdiction is not like the DA's office where we can just look at anything. We have very specific designated areas that we can go into. First one is fraud in the actual administration of the program. This means if there's a bad or an evildoer in the program itself, you know, an agency, staff member, or something like that, we can investigate that. We can also investigate anything having to do with the provision of medical assistance and the activities of providers in the Medicaid program, essentially any Medicaid provider, any healthcare provider who's enrolled in Medicaid, in other words, they do their billings through Medicaid, is a Medicaid provider. So any doctors, pharmacists, transportation companies, optometrists, anybody that bills Medicaid is fair game for us to take a look at. The third one you're probably somewhat familiar with because we get a lot of press on these cases. It's the abuse, neglect, and the misappropriation of patient funds in nursing homes, as long as those homes are funded by Medicaid. The individual patient involved doesn't have to be a Medicaid patient, but the home has to receive some Medicaid money for us to be able to be involved. And the fourth one's a little bit of a catch-all. It's kind of unique to New York. This is not part of the federal mandate. It's just something that our state has asked us to do. And it basically allows us to look at any entity or provider or healthcare deliverer who is under the oversight of the New York State Department of Health. So anything that the Department of Health would have oversight of, we also have jurisdiction there. And if you'll notice, there's nothing in there about us having jurisdiction to prosecute people who are on Medicaid, the recipients themselves. That is not our primary focus. We leave that to other agencies. We're mainly focused on the activities of the providers, the ones who deliver the care to the recipients and then who bill Medicaid for those services. But that's not to say that we can't prosecute a recipient. We do that sometimes in the context of one of our investigations of a provider. We'll find out that there's a recipient involved somehow or it's exposed during the context of our investigation. We would then have jurisdiction over them as well. Our investigative powers are pretty much like any other agency, a prosecutor's office or a police department around the country. But basically it's kind of unique because it's all under one roof. Where the DA's office might have to use the police to do their investigations, we have our own investigators. Or while a police department may have to get a subpoena from a DA's office, we can do that ourselves. And one of the things that's a little unique is number 2 up there, the regulatory discovery. Every Medicaid provider is required to keep records to back up their Medicaid billings for a period of at least 6 years. And by regulation, they're required to turn those records over to the Medicaid Fraud Control Unit when we come knocking. And if they don't, they're subject to various sanctions. So it's, sometimes we can get those records just by asking for them without having to go through any kind of criminal process. What I call extra prosecutorial powers, these are things that we can do above and beyond actually prosecuting somebody for a crime. The number one thing is bringing civil lawsuits. While we are mainly a prosecutorial agency, we do have civil attorneys, and we will file lawsuits to get back the money that was taken as part of the fraud. Sometimes we do that in conjunction with the criminal case. Sometimes we just don't have enough proof to prove a criminal case beyond a reasonable doubt, and we will just resort to a civil case. And in doing so, we can ask for damage multipliers. There's various statutes that allow us to ask for multiple damages. So if they stole $1 million, we can get perhaps treble damages, which is another $3 million on top of that. So it really kind of gives us a good leverage when we're doing some negotiating with the perpetrators. Number 3 up there is administrative withholds. We can ask the Department of Health to basically withhold future payments to Medicaid providers. In other words, these guys have been providing services, they've submitted claims for those services, they're expecting payments. But we've come along and determined that this provider is involved in some kind of fraud. We can then ask on that basis to have their future payments withheld until we can figure out the value of the fraud or whether there in fact is a fraud. And it really works very well to bring the perpetrators to the table. And also, you know, first of all, it stops the bleeding because if they're doing some bad stuff, we're not going to spend out any more money on it. And down the road, when we finally do get them, they're probably going to almost be out of business and bankrupt because they're paying lawyers and, you know, all kinds of things like that. We're going to at least have some money that was withheld that we can apply toward the restitution that they're going to owe us. And the bottom one is settlement agreements. Sometimes we don't even bring a civil case. We'll just call the provider into the office, tell them what they did wrong. If we don't think it was anything criminal, just a mistake, they will agree to settle the case, pay us back some money, and you know, that's the end of it. Now a couple of war stories. Nope, run out of time. Can I do just one quick one? I'll do the second one because it's a better case. This is a great example of the doc in the box case that Greg was talking about. We had a doctor, Dr. David Romer. He was a doctor, a physician in Ulster County, and he was willing, because to support his own drug habit, to sell prescriptions. And a bunch of enterprising individuals down in the New York City area got wind of this. They worked some things out with Dr. Romer, and basically what they did was they rounded up folks from substance abuse clinics down in the New York City area and transported them in a van up to Ulster County to see Dr. Romer, and along the way they gave him money so they could buy the drugs, from, the prescriptions from Dr. Romer. So this was the procedure. They drove him up there, they went in, spent very little time with the doctor, no real medical care was going on, and they would come out with a prescription. They would then take that prescription back to New York in the same van and go to a pharmacy, and then they'd all line up and cash their scripts. Once they had their drugs, most of it controlled substance with some high street value, they would basically sell it to the guys who organized this thing in exchange for $100, and then the guys who organized it would take the drugs and sell it on the street. So everybody made money. The doctor got paid the cash from the script buyers. The script buyers got paid the $100 by the guys that organized it. The guys that organized it got the drugs sold on the street and made money that way. And even the pharmacy got paid. The only problem is the taxpayers of the state of New York were out of a lot of money because 76% of those scripts were actually issued to Medicaid recipients. And over a 3-year period, Medicaid paid more than $1 million for the scripts written by Dr. Romer. And it's interesting, if you look at the average number of controlled substance scripts that he wrote per week, we did it for a 3-year period. In year 1, he wrote 1 per week on average. In year 2, 19. And in year 3, 71. So you can see how quickly this could escalate. And Lord only knows how much he would have written in year 4 and 5 had we not intervened. So that's a good example of the kinds of cases that we are interested in making. If you are a law enforcement agency and you have a case that you think we can be helpful on, please do not hesitate to give us a call. We're at your disposal, and we will certainly work with you. If you're not a law enforcement agency or someone who works there, but you have some information you think would be helpful to us in trying to, end a problem that you see a little piece of, again, don't hesitate to give us a call. We take every report very seriously. We will investigate it. We may not be able to do anything about it. Sometimes another agency can help more than us. We'll see that it gets to the right place, but I can guarantee you we will look into each and every report that we receive. Thank you very much for your attention and your interest today.